Good afternoon and welcome to today's program titled Treating Personality Disorders, Staying Engaged, Tolerant, and Firm. I'm Julia Brown, Associate Editor for Addiction Professional. Today's program is a Foundations Recovery Network webinar sponsored by Millennium Health. Thank you to our sponsor and to those in our audience today for giving us your time and attention. Before we get started, we have some housekeeping details.
This is Adam Armstrong. I'm with Addiction Professional. Just jumping in to complete Julia's notes quickly. So on the webinar console here, you'll see a number of icons listed at the bottom of your screen. The red Q&A widget will allow you to submit a question at any time, so feel free to submit that question even prior to the Q&A session beginning. And the resource list will allow you to access the website links and download slides, and you'll be able to do all of that with the presentation. The help widget will allow you to troubleshoot any technical issues you might be facing with the program. So go ahead and click on that widget to go ahead and troubleshoot the issue. And you can also submit any inquiries through the Q&A box. We'll also address those. Any CE inquiries. So if you have any questions related to CEs for the program, please click that purple Submit CE Inquiry button at the bottom of your screen, and you'll be able to see that. So if you have any questions regarding CEs, you can do it there. And you can also register for the next AP webinar sponsored by Foundations through the URL widget, which is located, it's sort of that magenta color at the bottom of your screen there. And Julia, I think we have you back here.
Yes, I'm back. So I will at this time introduce our speaker today, Dr. Philip Hemphill. Philip is the Chief Clinical Officer for Lakeview Health and is responsible for the planning, organizing, implementing, and directing of the company's addiction and behavioral health clinical services with cost-effective methodologies while ensuring quality of those services. He has presented papers and workshops at national conferences and published articles in the field of trauma, personality disorders, and addictions during the past 25 years. Philip has also been an adjunct professor at Tulane University School of Social Work for the past 17 years and assistant clinical professor at LSU Health Sciences Center, Department of Psychiatry for the past 15 years. He received his master and doctoral degrees from Tulane University. Thank you so much, Philip, for taking the time to speak with us today. And with that, the audience is yours.
Thank you very much, Julia. I'd also like to thank Foundations and Millennial for this opportunity to speak today. I really enjoyed the conference a few weeks back on this topic, and it was a wonderful time to get together with colleagues and exchange ideas and concepts and just to spend time together. So today what I'd like to do is take you through some of the work that I've been doing the past 10 years of my career related to treating personality disorders in the context of addiction treatment. And with this information, I hope to stimulate people to bring the best practices to their work environment, their individual private practices, their classrooms perhaps, or their treatment teams to refresh discussions that I think are important and well needed. What we know about personality disorders is that there's a power of perspective and that there's not always a black or white definition as far as who fits into these categories or not. Now, if we're in a treatment setting where there's multiple people around, what we do see is we know it's a problem when it's a problem because it's creating, distress, disruption in the milieu. So it's really important to have preparation for how to manage, how to intervene, how to assess individuals with this particular proclivity. You know, the title that was chosen here had to do with how to keep people engaged in this process. So, and how can we maintain our tolerance and at the same time be firm for accepting people into this treatment process here. So one of the articles that was really important to me when looking at this had to do with how to keep people motivated, how to keep people engaged with their peers, and the realization that their treatment is, let's see. I'm going to move forward here. So part of this requires us to have a certain amount of attachment. And what we know about attachment is that we're expected to be attached in our treatment process, and using this informed therapeutic technique. So through attachment, we're expected to be consistent. We're expected to be expression as far as the individual's ability to bond with us. We're expected to promote self-dependency as well as help-seeking behavior. We're expected to be attuned, maintain our connection with people. We're expected to be close, as well as manage the countertransference issues. So with all of this expectation, we need not look far when we're looking at personality issues. So sometimes, if we just look outside into the parking lot, we can see some things here. So for example, a parking lot here where we can do some diagnostic assessments ourselves. So if we see the person in the first one here, perhaps the paranoid is sort of blocking people in. The second one is taking up a big space there, the narcissistic space. The dependent, which is side by side, fitting in one parking place. And then moving on through the different personality characteristics here. Now, while this is really enlightening perhaps, one of the real important things that I've found is the need to maintain our professionalism and be reminded of, really that we're expected to have this complex body of knowledge and skill as well as the ability to articulate what we're doing. So the blending of science and art, and that we're governed by a certain code of ethics. We need to, I think, be reminded of our professionalism, especially when managing personality and character issues. So why is this important? Well, because society really needs and wants professionals to exist, to be able to feel a sense of trustworthiness and safety, and to gather people together to be able to intervene like this. So I know there's a lot of joking sometimes made regarding personality issues, especially in treatment teams. People use sort of garbage can diagnosis sometimes, but it's very important to maintain our professionalism. So one thing that I did is included the word personality in the title because, Confucius says, before we can change things, we must call them by their real name. I think sometimes people shy away from the idea of just putting a label on someone, the difficulties with communicating or coming to a consensus when it comes to diagnosing a person. I think that's why it's important for us that if these things do exist, that we call them for what they are. We sort of address them as they are. So let's just sort of start with just a regular definition of personality. And, the distinction of each of us individually and those distinguishing characteristics that make us socially appealing. Now, the difference here is personality disorder, really the main word is at the bottom, which is the characteristics that make us unappealing. And so that sort of lumps a person into the category here. Well, I said earlier that it's not really a problem until it's a problem, because there's always a continuum here. So if you have a behavior such as suspiciousness or vigilance, and if that sort of goes to an extreme, well, then you sort of move over into the category here where it's diagnostic. A lot of people in this world, a lot of people in society are looking to, really look out for oneself. And as you do that, if you do too much of that, you become narcissistic. Some people just, like to be attached to others. That's really important. But, if you do too much of that, again, there's dependency. So you can see that these things do exist on a continuum. And so really the definition here has to do with an enduring pattern of inner experiences and seeing the world relating to others in a manner that markedly deviates. So this enduring pattern that markedly deviates from the cultural expectations and results here. And this is habitual behavior that is pervasive and inflexible. So those three underlined areas best to me describe this pattern of behavior, markedly deviating, and that's pervasive and inflexible. Now, the onset of these occurs usually in adolescence, and what we do know from most research tells us that this early onset usually have more severe symptoms related to substance use, usually have more difficulties functioning socially, as well as the frequency of use of drugs are up, suicidal behavior is up, and that so we know that the risk of substance issue and relapse and having a protracted intervention is definitely there if you have a personality disorder present as well. These are usually long-standing, causing, severe distress in other people, as well as, some of the, as I said earlier, some of the personality traits may not necessarily be pathological, but they certainly can impact one's functioning and interpersonal relationships. So just to sort of sum up some of these characteristics, demanding and actively or passively non-compliant, over or undervaluing oneself. These are the behaviors that are exhibited in the treatment world, the things that we see in the context of a treatment process, that if you have a person with some of these, the indication of a proper assessment and intervention would be highly recommended here. So these are not uncommon. That's why people are in treatment. That's why they're engaged in substance use disorders and the addictive process. Which one is first? Which one causes what? But certainly that they're present is really typical here. So having this lack of awareness, the impact on others. I frequently see people in a group, well, they'll just make a joke or some comment that's crude and not really even read the social cues of the response of the other members of the group. So that social lack of social awareness and how one is impacting others. And so, we typically, again, using more pejorative language here, we hear words like the cluster A, going back to DSM-4, they're the weird. The cluster B, well, they're the dramatic and they're the wild. And then the cluster C is that they're the wimpy. So the three W's, you'll often hear people describing these in the context of communication professionally. And there's an opportunity to intervene and to sort of teach people, use teachable moments in looking at people's transference, countertransference, the groupthink, how people are just responding to these different individuals. All of this started with regards to being diagnostic about 4 decades ago by Robbins and Goose. And these individuals suggested that there were 5 criteria for diagnosing people. And this eventually became the DSM-3 and the different axes. And they just said that we needed to look at clinical description, we need to look at laboratory tests, we need to just do a reductionary diagnosis here, we need to follow people up, and we need to get some collateral data. That was the things that they suggested from their research diagnostic criteria done in the 70s. And this, again, became what we have today, which is this multifactorial way of procuring information. And so, more recently, the research domain criteria by the National Institute of Health has really looked at the integration of genetics and neuroscience and psychology. And it's sort of like an accent in trying to diagnose people and coming up with some very important empirical evidence to support the use of these diagnostic criteria. And it's almost in the face of the APA. I don't think that they're going out, that they have contention, obviously, because this is a government agency, but they are doing some things to put numbers to this. So, the idea of the negative valence systems or this sort of this aversive sort of motivational dimension that somebody has, like this fear and anxiety and threat and just this frustration and a high level of loss, that might sort of have a variable there. More positive valence, so that if somebody exhibits validation and effort and willingness and expectations, they want something different, then that's where we would see more in this positive variance domain here. And then the cognitive would just be people's attentiveness, their memory, their language, their control, those types of things. And then socially, how are they doing in affiliations, the types of people they're affiliating themselves with, their attachment styles, which I mentioned earlier about us being an attachment figure. Really important to be transitional objects for some people in the context of attachment. We're expected to do that in very short amount of treatment stays and short even sessions that may be limited for individual, but there's still a need to use attachment as a style for engaging people and being that secure base for people. So, and then lastly, just sort of the regulation of one's, their arousal systems, and that their ability to rest and wakefulness and sort of regulate themselves. So, that is sort of this new model of integration that's being researched, and people can sort of attempt to be a site where they would do more of this at the current time, at this time, with regards to trying to validate these domains. Well, just doing some of the inventories for the personality disorders related to the DSM-5 and some of the more informed reporting is really getting at all of these different dimensions related to personality. So very exhaustive here as these assessments are being developed related to understanding personality disorders. Done, although some of them are lengthy, most of them are not, as we had in the past. So very important that we're having access to this. So again, looking at some of the antagonism and disinhibition and detachment types of domains. Very similar to what this research domain criteria mentioned earlier. And then, this article by Trestman talked about, is there really anything new? And the reality is no, that the DSM-5 has the exact same Axis 2 diagnosis that we had in the DSM-4. So there's been no change from the Big Ten. So cause and, what's causing personality disorders? I'm sure most of us are familiar with this, but, the idea of causal relationships are very complicated and multifactorial. And so, there's various theories. The leading ones look at normal and healthy development, and somehow that gets interrupted. I mentioned earlier about the genetic component. I mean, the predisposition, which I'll have an article in a minute, but that's also a causal relationship as well. So we do know about abuse and neglect is pretty prevalent a lot of times. Severe emotional and physical and or sexual is certainly there. And then some people just sort of wear these as sort of their badge of courage as it relates to their personality when looking at some of these interruptions and some of these causal factors. And that holds true for, say, the attachment the attachment literature on the adult attachment interview, and it sort of asks a question in a projective way, and it sees how a person responds to that. So if the person is sort of feeling like that is still going on in their historical presentation of an event or something that occurred with their family, well, then that's a certain attachment style. So that's what that's saying is the badge of courage can affect the perpetuation of the characteristics here. So here, as far as the genetic load and the genetic contribution, we certainly know about familiar and twin studies. And at the same time, the vulnerability to substance use here and the resiliency is being tracked through scientific measures and looking at the development of the brain and the communication and the neurochemistry that's taking place. So there's underpinnings here and the potential for disease syndrome itself, and it looks at these different biomarkers that increase the probability of a person expressing it through some personality or character difficulties or personality disorders here. Now, the positive emotional, the sort of extroversion, these are, again, extending it to sort of if a person has a lot of these positives, well, they're going to be much more resilient related to personality and character and much more enthusiastic, and their factor is going to be much higher, as opposed to a negative, and that would be someone with a lot of anxiety and guilt. So in looking at this, you look at if a person has a negative emotionality and has a poor impulse, control, their choice, their action is there, where they have a difficult time constraining themselves, they seem to be the most vulnerable related to substance use disorders in this model that was developed by Belcher and colleagues. And just, another instrument looking at character and personality on all these different dimensions related to novelty seeking, harm avoidance, reward. Those would be some of the temperament, and then the character related to the ability to self-direct and be cooperative and move forward. So these are just, again, looking at high and low dimensions related to development here. So some of the features shared by substance abuse and personality disorders that interact and reinforce one another are important in clinical work. And so the summary here is that they're both very difficult to diagnose. So oftentimes substance issues can be very challenging and may take a period of time, may be progressive in nature, just like character and personality disorders. And then, they exist, back here, they exist on a continuum here. We know that, as mentioned earlier. Both are suspect to poly disorders, so having multiple substance use chemical issues and alcohol being crossed over here, as well as personality and character. Both sort of have the idea of denial and difficulties sort of accepting accountability and responsibility, and just sort of immature defenses substance use disorder individuals, as well as personality disorder, have an immature defense mechanism, difficulty accepting feedback, and just the expense of treatment because it's so protracted and extensive. And so temperament, and blending these two, is the genetic component that the constitution of the contribution for the personality refers to this inherited sort of disposition mentioned. The character sort of comes from engraving, refers to this idea of learned and socialized, and together these two make up personality. So Verhoeven looks at these three causal and developmental pathways to addiction in which personality factors may contribute significantly, as defined by these, behavioral disinhibitors, the stress reduction, as well as the reward sensitivity here. And so, looking at in the behavioral realm, these are the typical personality disorders that are present, the pathway here, and these are the particular substances that an individual may have the propensity for. Then a stress reduction, these are some of the personality traits that you see, and followed by some of the substance use issues that may be present, as well as the reward sensitivity. These are much more dramatic individual and using many different substances. Again, it's just sort of a hypothesis there. Now, being a little more specific here and looking at this from the behavioral disinhibition, people with these, antisocial, impulsiveness, low on harm avoidance type things, you can see that, individuals going across here, the deficits in serotonin from the behavioral disinhibition, the deficits in socialization leading to addiction. That would be more the behavioral pathway. The stress would be sort of this interrupted or the difficulties with, regulation, self-regulation, moving on to using the substances to self-medicate. And then the reward, just looking to feel better, dopaminergic type of responses, just needing excess. That's the other pathway. So having multiple pathways can be present in different individuals or across an individual. Between they may exhibit the multiple pathways themselves. So one of the things I think is important is just reframing this problem and looking at the disorder here as a way of understanding a person's ability to cope the best way they knew how in response to their, whatever it is, genetic, their predisposition, their traumatic interruption, whatever it is, and their ability to adapt. And what they've used to adapt has become maladaptive. So those are the two key words here. So mapping out what, you can look at from a risk standpoint and looking at stable dynamic factors, stable versus dynamic risk factors here. You look at disordered cognitions that can increase from a schematic standpoint, the interpersonal difficulties, the self-regulation, and then the poor scripting and ability to cope. So, it's often been said, page 1 of Bill Wilson's book, says that we are interested only in we're interested only in alcoholism. It's often said that is not true. We have to get over drinking in order to stay alive. But anyone who knows alcoholic personality by first-hand contact knows that no true alkie ever stops drinking permanently without undergoing a profound personality change. So the importance of addressing character and personality is right there on page 1. And then again, an anonymous author wrote here in a little red book, this 1975 about the devilish alcoholic personalities. And none of us was born with these personalities. We developed them throughout many years of uncontrolled drinking. And again, I think just the pejorative nature of devilish, ghoulish, is where personality sort of gets its reputation and is often reinforced. Now, interestingly, in the research that I did here, I looked at, despite people, having personality disorders, their actual completion and readmission, even though earlier some of the data said some difference here, but that there wasn't that big of a difference between people who had success rates in addition to personality, despite that being a focus of this lecture in and of itself. So some studies back from the 90s, I think, by Nadal and looking at the prevalence of Axis 2, certainly present there, and the importance of treating these, even though, some of the more recent ones saying that there's not a difference. Now, this was a really profound piece here from Freiburg related to a meta-analysis that had a very high N here, and looked at the presence of personality disorder as a comorbidity with mood disorders, and saw that it had a much higher rate in females, higher in cluster B. There was no difference between inpatient and outpatient, and no difference between the U.S. and Europe. So if there were mood disorders, there was a high prevalence of personality disorders. So just to integrate that as well, so that we don't leave that part off. Then there's some very robust instruments out there now for screening personality disorders and standardized assessments that I think are invaluable. And here's just a few, and a site that you can certainly access to have these individual instruments. They're very robust and well researched. And just back to Verhoeven and the prevalence here, and just mixing up more reinforcement that there's not really artifacts related to the presence of personality. And they ultimately, the conclusion is that very similar to what I just said, reinforcing the diagnosis of substance abusers, not having an artifact of substance-related artifacts that you have to have. It can't cause the personality disorder, the substance issues. So just not really knowing exactly which one is coming first. So, personality disorders and how they affect business as usual. This has to do with the treatment process and the delivery of the treatment services. Well, ultimately, I was asked earlier about the modality, and we know that group and community and milieu are by far the best way of addressing these. At the same time, having access to some individual work is really helpful as well. But ultimately having that social model where there's potential for engagement and maintaining those firm boundaries and relationships here. Now, a really good model to just access to look at personality has to do the schema therapy here, and that it's looking at the cognitive, behavioral, attachment, object relations, experiential approach, and all of these obviously will address the title of this particular presentation with keeping people engaged and maintaining growth and productivity. And so going at the therapy in multiple different ways, I would invite people to have this as the backdrop in treating character and personality, just like the attachment world. And so just some highlights of things that you might consider, as people sort of like to think that maybe paranoid is something that you don't really see, but that's not accurate. Even highly successful people who are very accomplished, I've seen quite a bit of paranoia, as it falls behind narcissism and obsessive-compulsive, paranoia is there as well. And so the importance of, how to intervene and people feeling betrayed is really crucial. And then, doing some confrontation at times, it may provoke the individual hostility, it may escalate. So, doing a balance between, confrontation and patting a person on the back at the same time. Really important with the paranoid personality. The avoidance, sort of schizoid, they may have some limited verbal skills, so you may have to address them more in a social way and sort of do things more experiential with them. So that's really important. with the schizoid. So the schizotypical, they may resist treatment and medication for fear that it may make them ordinary, sort of don't want to be involved with the mainstream here. And so, these goals are similar to people with serious mental illness if they're exhibiting this particular personality, which is the social network and the development of social skills. And so overall, neuroleptics and antidepressants can be very helpful. And then you may see some of these chronic use of stimulants and cocaine and hallucinogens. Now, the sort of cluster B, as we get into the antisocial, few come into treatment voluntarily, usually have some external factors and motivation related to that. And a nice study done by Holdsworth and colleagues in 2014 looked at a review of 47 studies related to character and personality. It's in the Journal of Aggression and Violent Behavior, and really, evaluated a number of these sort of like the client evaluation of self and treatment, the multifactorial offender, looking at the offender base, and found that, even with external factors, people still have the commitment and the capacity for change. And a lot of times people may have difficulties being in the community and worried about the individuals here. So, Andrews and Bonta really, this has been going on for a number of years, but this is one of the better resources related to risk assessment and really responding to individuals. So what is their risk? What type of need do they have? And how we're responding to them. Now, this is from a criminal standpoint, but obviously with character and personality issues, we need to take this model into consideration as well. So with borderline personality, confrontation may be useful. With more higher functioning, attention to risk management is really important. And, just the idea of being consistent and maintaining boundaries and, not having this rescue fantasy, having a group sort of feedback related to supervision. So not, ending up outside of the tent, where instead of the camel sort of pushing its way into the tent and the individual being outside. So being able to maintain firm boundaries over the course of time. This story has to do with, traveling across the desert here, having a tent, and then about as the sheik sort of lays down, beds down for the night, the camel pokes his nose into the tent and says, "Can I just leave it here? It's really cold out here." And the sheik says, "That's fine, leave me alone." Then about 2 a.m., "Can I just put my ears inside the tent?" And eventually there's an exchange that takes place here if more and more doors are open. So the histrionic personality, difficulty in delaying gratification and encouraging that, and confrontation can be useful. And then the narcissistic is again not likely to enter through self-referral, usually some external, and just this idea of trying to encourage humility and dealing with the steps related to this mask of grandiosity. And so again, some of the SSRIs are important in managing these. Lastly, using dialectic behavioral therapy with this particular group can be of quite success that we know, and sort of blending of some of the psychoanalytic psychodynamic therapies as well. And looking at some of the cluster C, having the avoidant, usually very slow, may have multiple readmits. Relationship addiction may be powerful for the dependent individual here, as well as, early in treatment, they appear attentive, appreciative, easygoing, and then the real change is required, there's resistance. So I was once told in my training that no resistance is all resistance. So I think that this could be something that's present with the dependent personality. So the importance of validation and again, setting limits, confrontation, being mindful of the substitute, being the substitute parent. So there goes back to that the attachment theory that was mentioned earlier related to this, and Now, the obsessive-compulsive, again, with the highly successful individuals, this being something that's more prevalent. In general, people are going to have some of these traits across the spectrum. Again, there's an appearance of compliance and, this effort to maintain control over the rules and even the individuals that are treating them. So these defenses are often masked as resistance and anger. You're not going to tell me what to do. And the group kind of holds back because they're afraid they don't want to make a mistake in their feedback to the individual. So that's really important that in a community setting that the group is able to offer that feedback with the obsessive-compulsive because they're affecting them. Not that the rest of these aren't, but that's one that they can usually tangibly hold on to and not feel as threatened when they're giving feedback to the person, because there's usually behavioral observation. And so confronting these defenses, it needs to be in control. The person, even though they're being confronted, you still sort of give them control, and it's a balance, as mentioned earlier. And so to wrap things up, this idea of character and personality is not new, but it's certainly populating the treatment environments that I've been exposed to and I've been a part of, and the power of feedback and having multi-source feedback is ideal, not only for the individuals but for the staff who are managing these particular cases, working with people individually, working with these individuals. It's important to have multi-source feedback and supervision as the challenge is there. And we know that despite the success slide here as far as their responsivity, we do know that there's more dropout, less compliance related to the treatment process, make things more challenging internally to the staff. And so, we don't always need to just look at things as far as how people are doing something wrong, but it's really important to catch people doing something good, not just sort of focus on the negativity as it's related to the treatment process. So with that, I'll sort of move forward and turn things over and be responsive to any questions that may be available.
Thank you again, Philip, for a very informative presentation. Before we get to the Q&A portion of today's event, I would like to now hand things over to Melanie Belcher from Foundations for a few words from our sponsor.
Thanks, Julia. Here at Foundations Recovery Network, our grassroots movement called Heroes in Recovery has a simple mission: to eliminate the social stigma that keeps addicted individuals from seeking help, to share stories of recovery for the purpose of encouragement and inspiration, and to create an engaged, sober community that empowers people to get involved, give back, and live healthy, active lives. Join us in this mission at our 6K race series at these locations across the country. As a thank you for your attendance today, please enjoy the discount code WEBINAR2015 to register for any future 6K event. Back to you, Julia.
Thank you, Melanie. We've already had a number of questions from the audience that have come in. However, we would also like to remind those in our audience to use the Q&A widget below the slides on your screen to submit a question at any time. I'll start with our first question. If we as professionals already have a preconceived idea of what a drug addict is like, we may have difficulty providing unconditional positive regard. Do you feel recovering professionals have an advantage in providing treatment?
Yes. I think the perspective that the individual has can be communicated. Whether a person chooses to reveal that history or not is up to them. But I certainly think that a person having experienced some type of illness, disorder, addiction, whatever it is, we're talking about personality here, certainly that enhances their ability to manage and assist others. We respond to people and we engage in our interactions with people as professionals through our own life experiences, whether you've had them or not. You sort of make comparisons unconsciously. You think about your previous relationships. You think about the person you ran into on the way to work that day, or the stress that was caused on your way to work. These things are always present for us. So I definitely think that an individual's history certainly plays a role in their ability to practice and be successful, yes.
Great. Do you think that substance use in itself sets the individual up for detachment disorder since the behavior is socially unacceptable?
Well, I think that from a societal standpoint, the definitions of substance use is what sets people apart. I mean, individuals are engaged in a social network, even through the process of active addiction in the process of using. So they're exchanging social interactions. The model is just, socially rejected by society, but there's still social skills that are being developed through the course of a person's life, even in the component, even in the process of using. Now, does that increase the probability or propensity for detachment in relationships? I would think it would have an influence over that and have an impact. And it may initially have a person make them difficult to engage, even in a therapeutic process. So that I think is partially true because the attachment has been to people who they may not really want to be attached to, or it's to a substance, or it's to a behavior, an addictive behavior, an addictive process. So that becomes the attachment experience or figures, as opposed to trying to free themselves to engage in a more socially productive, socially desirable behavior that's not sensation-seeking.
Great. We have another question here. How do you explain those that do not have abuse or neglect and have a positive upbringing but still have mental health issues or personality disorders?
Yeah, as mentioned, sort of you have this temperament, this genetic predisposition that is certainly present, and it is has been researched and has been identified. These biomarkers do exist. And so as people have this proclivity, it doesn't necessarily require activation through some type of stress or some type of disruption in their development. It could be just that there was a predisposition here, and through the course of living life is going to have stressors, change, create stress, and so it could make a person's ability to be vulnerable at a higher rate there, and they may just respond, they may have less resilience to the personality disorder characteristics, and eventually, develop this more of these and refine more of these through interaction. So they may gravitate towards certain behaviors or certain vocations or certain occupations or certain individuals, even though they may have not had a stressful life experience, and that may be the reinforcer from the behavioral pathway. Great.
We have another question here. How would you deal with an individual who has a personality disorder, perhaps a cluster B, and serve the purpose to influence peers in a therapeutic community in a negative manner?
Yeah, that's probably the number one. That's a great question. It's long, but that's probably like the number one problem that I think people are faced with in the context of a treatment center and a treatment milieu. And so I think sort of not allowing that person to have a profound influence over the group is the goal there, although that's very challenging. So there's infiltration types of issues that may take place. So having clear communication among staff at all levels, so that there's the best possible communication taking place between people who are interacting, who are part of the community, part of the staff, part of the peers, looking for signs that the person's influencing or impacting others in the more vulnerable individuals in the community. So being aware of that, and then modeling the types of behaviors that one would expect as far as interacting with the person in a group setting, or setting limits with them, or supporting them, picking and choosing times where you're going to sort of work closer and be more connected in an attached way with that person in the presence of others. So, that's really important to model for the rest of the group. So those are a couple of the things, in addition to the medication management, could be very helpful there. But that's a great question. It's a very complicated one that keeps a lot of people up at night.
Great. Another question here. Do you think that the higher rates of personality disorders in women can be attributed to the hormonal changes they experience during a variety of time frames in their life? For example, pre or postnatal or menopausal and general health issues?
Yeah, well, certainly you're looking at later life types of onset, one could make that hypothesis. But remember, this is something earlier onset here, and I think that females are more attuned and expressive in their behaviors, and so because they're more likely to seek out mental health services, they're going to be more likely to be the ones diagnosed with different things, and that some of the expectations in society, some of the just inherent differences related to their responsibilities, their biological makeup. I certainly think that hormones can play a factor in this. If you start with adolescence and the early onset of puberty there at such a young age, that can impact the socialization, the confidence level, and those things can just continue to unfold into the young adulthood. So I certainly think that certainly plays a factor and has a variable. I don't know that I would go as far as saying that that's what causes. I think there's other variables that cause, as I mentioned.
Great. Another question. How can we empower our operations staff members, behavioral health techs, et cetera, to support and engage in healthy, appropriate confrontation with clients who have a personality disorder?
I think maintaining a strong training program for individuals at that level is really important, and offering them support and services and making sure that their voice is important and that it's heard amongst the treatment team. And you may also utilize individuals with more experience and training, that they may get elevated in that group of people, so that they're leaders, and that would be some of the people that they may go to quicker to sort of express some of their difficulties that they're having with individual patients. And so I think treating that group, the group of associates, techs, counselors, however we want to call, as a really important group where there's specific training, there's reinforcement from the therapists, from the higher level professionals and clinicians, that there's a team approach, that everybody's voice matters and everybody has a potential to be a leader, and using the culture to reinforce the values of the organization is very important to those individuals, and empowering them. And so that even if there's a crossing of inappropriate behaviors related to them, obviously that they're the ones that deserve the protection, the intervention, that individuals don't have a right to do anything inappropriate to them, just like anybody else on the whole entire campus, including their peers. So I think empowering that group and maintaining a high level of training and offering some leadership within that group and following the values of the organization and transmitting those down to the expectations with the patients.
Great. I think we have time for 2 more questions. Here's another one. How do we as clinicians tell a client that they have a personality disorder without offending them?
Well, I don't think it's going to be a shock if you're worried about offending a person and them and saying it to them. Because if there's already an inclination that the person's going to respond in a negative way, then I think they're pretty aware that there's something going on with them. And I think through diagnostic assessment and a continuum discussion, that things start out or people are on this part of the continuum, and then there's some people and there's some times where you move over to this part of the continuum. I think that can be a way of communicating the information. Again, I think if it's normalized that everybody sort of has these characteristics and traits, but they're at different levels, that could be an approach. Having some empirical data to present to the individual, being again in a group setting where those things are discussed, I think is important. I think you have to use traits. You don't necessarily use diagnosis in a group, but you certainly can communicate what's going on and describe all of these things and put this down. And a person is entitled to having their diagnosis, and this is truly part of a diagnosis. So I think that's really important.
Great. I think this will probably be our last question, but do you have any specific DBT techniques that you have found particularly useful that you could recommend?
Well, certainly the mindfulness work is very helpful in assisting individuals to just sort of regulate that affect. I think engaging people into activities is really important. Not just sitting in a room, not just doing discussions back and forth, but sort of integrating their healing, their recovery into a full body mind experience, I think is key. I think Marsha Linehan just released the next edition of her series of books. So certainly that's good modeling related to DBT, and she's really pushed that forward in our field. So those types of experiential, using the schema therapy, that's basically a lot of DBT going on there as well, and using groups. Those to me are the best approaches to managing personality and character issues.
Great, and that's all of the time we have for questions today. We have some final instructions regarding CE credit, and again, should you have any issues with this process, do not reach out to today's sponsor as they will not be able to assist you in receiving a certificate. CE Learning Systems has approved today's program for 1 continuing education credit. To receive your certificate of completion, you must click the green CE certificate widget, complete the evaluation form, and click Submit. For those watching in a group, as a reminder, please download the group submission guide and program evaluation located in the resources area and follow the instructions provided. For those watching from a mobile device or tablet, you will need to email the help desk to receive a program evaluation and certificate for this program. Please note that CE credit is not available for the archived webinar, and this is only for today's live event. If you have any questions, please click the purple Contact Webinar Help Desk widget at the bottom of the screen. Please join us again on Wednesday, August 26, 2015 at 1 p.m. Eastern Time for another Addiction Professional webinar sponsored by Foundations Recovery Network along with Millennium Health titled Diagnostic Complexity, Treating Eating Disorders and Co-morbid Substance Abuse, presented by Melanie Smith of LMHC. A link will appear on your screen in a moment for you to register for this program. You can also register for the event by clicking the purple Register for the Next AP Webinar Sponsored by Foundations widget at the bottom of the screen. I want to thank Philip Hemphill again for this excellent presentation. I would also like to thank Millennium Health for making today's Foundations Recovery Network program possible. Finally, thank you to those in our audience for participating today. We hope you'll join us in the future for another Addiction Professional webinar. This concludes today's presentation.